All right, so thank you all for inviting me to speak. My name is Khanant Desai, and I completed my IR training at UVA, and I'm currently a surgical critical care fellow at Brigham and Women's Hospital. I'm excited to speak to you on the role of critical care in IR training. So I'm halfway through a one-year critical care medicine fellowship with the Department of Anesthesia after completing an independent IR residency. To my knowledge, I'm the only IR to have completed a SICU fellowship as part of their initial training. And this is the #1 question I get from everyone these days: radiologists, intensivists, nurses, my parents. So in this talk, I want to share why I think critical care training is crucial to the growth of IR as a specialty, and also give some examples through personal experience of how kind of acquiring these acute patient care skills can make you a better IR. So a little bit of background. In the beginning, there was this man, Charles Dotter. There's a picture of him in 1960. He's the father of IR and inventor of angioplasty. He has this very famous quote: if my fellow angiographers prove unwilling or unable to accept or secure for their patients the clinical responsibilities attendant on transluminal angioplasty, they will become high-priced plumbers, facing forfeiture of territorial rights based solely on imaging equipment others can obtain and skill still others can learn. So, there's always been a desire to become a clinical specialty. And of course, we all know kind of the background of how IR has evolved and a lot of times lost procedures. So in 2014, there was a redefinition of IR/DR training, with the major driver of this change, as Dr. Kaufman says, being the importance of non-procedural patient care and the necessity for additional training in such. So let's talk about patient care in IR, why it matters and how it can be optimized. So what is non-procedural patient care? Well, to me, it comprises these two things. There's the longitudinal management of patients using disease-specific expertise, and then there's acute management of patients in the hospital in the peri-procedural period. As you've heard so far today from some of these amazing speakers, IR is doing a fantastic job of establishing themselves as disease experts on par with hepatologists for portal hypertension, or vascular surgeons for PAD, or surgical oncologists for HCC. But how are we doing on this part? The reality is IR takes care of the sickest patients in the hospital. These are all real scenarios that I've encountered. Ask yourself, would you know what to do if the following occur? Acute severe hypertension that can't be treated with labetalol and hydralazine. Someone with cardiac arrest in the pre-procedure bay before hemodialysis circuit declot. All of these have happened to me. If your answer to these questions is that the primary team will evaluate and manage the problem, or you're going to wait for the code team to arrive, you've missed the boat. An IR with a focused mastery of critical care knowledge can improve outcomes in each of these scenarios. So why emphasize acute non-procedural care? Well, if you assume comprehensive responsibility of the sickest patients, you're going to deliver faster care with improved outcomes. This is going to generate greater trust and increased referrals, and that's going to lead to the growth of your practice and of IR as a specialty. What do we need to learn? I kind of think of acute non-procedural care in these three buckets. There's inpatient admission and management, there's inpatient consultation, and there's management of peri-procedural emergencies. And how do we learn it? To me, there's three major educational opportunities for learning acute care. So there's inpatient consult and admitting service, there's critical care training, and then there's didactic education. So I'm going to pause and kind of go into my story a little bit. The road to critical care fellowship. So, I've always wanted to be my patient's doctor, and I sense that a lot of you share the same desire. I don't want to just be their proceduralist. So on my required SICU rotation during the ESIR year, I approached the program director of the SICU, who was an anesthesiologist, with my vision for mutual benefit to both specialties. He loved this idea, and I matched. And so I completed my independent IR residency at UVA, and I came back to Brigham for a one-year anesthesia critical care medicine fellowship. I made sure to have dedicated IR elective time during this year. There was some resistance, of course, and some misconceptions with my plan as well. How will you keep up your IR skills? I think that's a great question, and that's why I wanted to have dedicated IR time this year. What makes you think you can work in the ICU after 1 year of clinical training? Do you even know how to manage inpatient diabetes? Literally, a nephrology fellow told me this as soon as I met them. And that is why it's crucial for everyone to work hard during their training to do the reading and to keep up with clinical care of patients. My personal favorite, do you hate making money? I don't have an answer for that. It is 1 extra year of training. It's really useful to have a radiologist on rounds to interpret images. On surface, this is a great notion, but the important thing is you don't want to get pigeonholed when you're doing your critical care training into being the radiologist on service. As Dr. Vatican Cherry says, you're there to learn critical care. You're not there to just be the radiologist on service. And a lot of IRs feel and have told me kind of you're pigeonholing yourself into an IR niche of trauma, bedside drainage, GI bleed. That's not what I see this as. I see this as augmenting my skills as an interventional radiologist to become a better doctor overall. These are just some of the things I've picked up over the course of the year and I'm still learning. Physiology is #1. It's something that we don't get in our traditional radiology training. And of course, is the core of critical care training. Things like bedside focused cardiac echo to assess for hypotension, bronchoscopy to treat hemoptysis. We treat it from inside the vessels, but imagine if you also knew how to treat it from within the airway itself. ECMO is a very interesting opportunity. It's kind of one of my passions this year. We can do these procedures. We can cannulate someone from ECMO. That's our bread and butter. Imagine if we also knew the physiology that goes along with it. It opens up a whole world of possibilities in IR. So I'm going to go into kind of an imaginary case here, but it's something that is kind of a conglomeration of things I've seen over my IR training and critical care training. So this is a 55-year-old female executive, history of smoking, COPD, OSA on CPAP, hypertension, coronary artery disease, and heart failure, who developed severe right lower extremity pain and swelling after a flight from London to Boston. And of course, you see this on exam, and they get an ultrasound that shows a DVT. So in the ED, they start a heparin drip, and IR is consulted for consideration of endovascular management of DVT. So you go and see the patient, and as you're talking to her, she starts telling you about some new onset chest pain and shortness of breath. And as you're speaking to her, her vitals pop up on the screen, and they show a systolic blood pressure of 92, tachycardia, tachypnea, and an oxygen sat of 87%. She does appear euvolemic on a lung exam. So there's some immediate physiology here for you to address. Despite her history of COPD, she's citing less than 88%, and she's got dyspnea. So she actually has hypoxemia. And given her history of hypertension, a systolic of 90 represents probably significant hypotension here. So you recommend O2 via nasal cannula at 4 liters. You want an O2 goal of greater than 88%, and you recommend getting a chest x-ray. Given her history of coronary artery disease, you're concerned for an MI, and you ask for a 12-lead EKG and serum troponin and BNP. On the positive front, she took her home aspirin, and she's already on a heparin drip for DVT. And then lastly, you recommend an A-line for monitoring her blood pressure and for access for future ABGs should you need them. So you get this EKG, and again, this is something you don't typically look at when you're on IR training, but absolutely something you should know at least the basics of. The EKG comes back without any sort of ST elevation or depression, a normal or a regular rhythm, and tachycardia. The troponin comes back at 80, and so it's elevated. The BNP comes back at 350, which is kind of in the intermediate range. So you, at this point, have diagnosed her with an NSTEMI. Now, is this a type 1 or a type 2? Hard to say. Your next step then should immediately be a bedside-focused ultrasound of the heart. Now, we're radiologists, right? But for whatever reason, we've given up echocardiography. And while we don't have to be echocardiographers and do a 45-minute exam, I think every one of us should know the basics of focused cardiac ultrasound. And so this is an example. This is a peristernal short axis view of the heart, and this is a apical 4-chamber view. And what we're seeing is the left ventricle here, the right ventricle here, and here we're seeing RV, RA, LV, and LA. And so important things that we're noting immediately. There's no pericardial effusion. There's no gross regional wall motion abnormalities. The LV is normal in size and function, but the RV, which should not be bigger than the LV here, is large. It's moderately dilated, and you do what's called a TAPSE. So you measure tricuspid annular plane systolic excursion just to see what the RV function is. And you find out that it's 16 millimeters, which is below the normal of 17 millimeters. So she's got a dilated and hypokinetic RV. She's an RV failure. You also look at her IVC real quick and you see that it's plump and there's no respiratory variation. And so she's certainly not fluid underfilled. You get this chest x-ray and honestly, it looks pretty normal. So at this point, this patient has a type 2 NSTEMI. She's got shock with RV failure and dilation, and she's got hypoxemia. Why? So now you go through your differential of shock. She could have a type 1 NSTEMI from coronary ischemia. She does have a history of CAD, certainly. She could have acute flash pulmonary edema, but this is less likely from a normal chest x-ray and a euvolemic physical exam. She could have septic, cardiogenic, or hypovolemic shock. These are all less likely, though, because she has no history of infection, no STEMI on EKG, an unchanged ejection fraction in her left heart, and a plump IVC, which tells you that she's not fluid underfilled. A PE can cause obstructive shock, and it can give you this constellation with hypoxemia. And so this absolutely has to be ruled out. So how will you treat the initial hypotension? Well, typically you give IV fluids, right? But you just did an echo and showed that she has RV overload. And so you, in your mind, have to be very judicious about the amount of fluid that you give her. So you go to your ED colleague and you tell them all of this and you recommend a CTPA. You think she has a PE. But the patient develops oxygen sat now, again, less than 90 while she's on nasal cannula, and she reports worsening dyspnea. The nurse tells you she's too unstable for the CT scanner. You also draw off an ABG and it shows a pH of 739, a PCO2 of 52, and a PaO2 of 74. You have to know what type of respiratory failure is this. Now, initially, you might think that the PCO2 of 52, which is elevated, might make this hypercarbic respiratory failure, maybe from hypoventilation. Maybe she's just not breathing as fast as she needs to. But then you look at the pH and you notice that it's normal. And so that tells you that this is actually probably compensated COPD. She's a compensated retainer. So she does have a low PaO2, and you can surmise that this is hypoxemic respiratory failure, which again can happen from a really significant pulmonary embolism. Now you need to start considering higher levels of respiratory support. So you can think of a non-rebreather that can give you 6 to 15 liters of flow. You can think of high flow nasal cannula at 10 to 40 liters of flow. But also you got to start thinking of things like BiPAP or even intubation. I, at times, have made the call to intubate someone on my initial consultation in the ED as an interventional radiology fellow. Well, now her systolic remains in the 80s. She's got MAP somewhere between the 55 to 65 range. It's time to think about a pressor as your concern for a massive pulmonary embolism increases. And so which pressor are you going to start her on? Well, you know, Levofed might be your initial go-to, and it's not a bad choice, but you have to remember that it does have alpha activity, and so that will raise your pulmonary vascular resistance as well. And in someone with a PE, that might not be the best option. And so then you got to think about things like epinephrine, which is actually a great choice. It's got beta activity, which will help her right heart failure, but it will also decrease your pulmonary vascular resistance and help out with that right heart failure. Vasopressin also has a similar effect. And so maybe you start her on some epi instead of levo. So she stabilizes and finally makes it to the CT scanner, and you get this. This is something we've all probably seen. It's a saddle pulmonary embolism. And so you've made the diagnosis of a massive PE. So then you run to your MD Calc and you calculate the PE severity index, the PESI score. You plug all these numbers in and you get a score of 145, which tells you that she's class 5, she's very high risk, meaning she has 10 to 25% 30-day mortality. Then you put it all together. So you go to your ED colleague, maybe your vascular medicine colleague who showed up at this point, and you tell them, this is a patient presenting with the DVT. She subsequently developed saddle PE, causing type 2 NSTEMI, hypoxemic respiratory failure, and obstructive shock with RV overload and failure. This is a massive pulmonary embolism with RV failure and hemodynamic instability, and she's got a PESI score of 145. What should we do, doc? So I want to make the point here, and this is the point of this whole case. If you are a master of physiology and acute care as an interventionalist, you will become the person that everyone will look to for that last, most important question: what should we do? You can intelligently give an opinion now on, should we give IV TPA? Should we do catheter-directed thrombolysis or thrombectomy? Should we think about intubating this patient? And should we even think about doing VA ECMO to support her right heart and her respiratory failure as we do some sort of intervention to clear this clot? So let's talk about some future directions in the time I have remaining. As a new specialty, there's a huge potential for expansion in each of these three educational opportunities. The easiest one is inpatient consult and admitting service. We all have limited or different amounts of resources as IRs, but this is something you can institute from day one. Ask for inpatient admitting privileges and write consult notes on your patients. Critical care training and didactic education I'm going to talk about. So this is the ABR VIR study guide for the certifying exam. There's 3 pages. This is page 1, this is page 2, and this is page 3, and we're talking about hospital inpatient care, inpatient consults, and principles of life support. I think there's a huge opportunity to expand things like an in-training exam, a core examination, and expand what's required knowledge for us in terms of inpatient care. Just for comparison, this is actually the surgery ABSITE exam, and you can see that 24% of their exam is medical knowledge, things like fluids, electrolytes, and acid base, transfusion, and disorders of coagulation. And I'm going to throw in a plug here for the SIR Critical Care Introductory course. I know Dr. V is very involved in this. This is a great primer on if you're interested in learning this stuff, where you can go to kind of pick up the basics of it. If you're interested in doing dedicated critical care training, this is something I'm very passionate about. I want to turn critical care into a subspecialty of interventional radiology. Now, there's a precedent for this. Pain medicine is exactly this. You can do a pain medicine fellowship and take the board examination through the ABA and get certified through the ABR in pain medicine. Again, if you're interested in this, I think we can get this done, and I think it would be a great thing for the field to have critical care be a subspecialty of IR. So back in 2014, we had this goal of becoming a clinical specialty. We've had that ever since 1960 with Dr. Daughter. And now the training is evolving to match it. We want not only diagnostic imaging expertise and procedural expertise, but now we must have patient care expertise. And I'm really excited that, everyone here is dedicated to that principle, and really looking forward to the future of this. So this is my references. These are some pictures actually literally from last night. I'm on a med flight elective, and we transported a stroke thrombectomy patient into the city of Boston. So these are just pictures from our transport. This is a picture of my former co-resident and now wife, lovely wife, and she recommended that I get a Twitter for this presentation. So please feel free to reach out to me with any questions, concerns, and thoughts about future directions. Feel free to text, email, or find me on Twitter. Thank you all for your attention.
Thank you, Dr. Desai, for that wonderful presentation. I want to introduce Terry Zhu, who's a 4th-year medical student at USC.
Hi,